Good morning, everyone. I'm talking to you from my backyard this morning because it's really a wonderful, beautiful morning here in Los Angeles. I wanted to talk about a subject that's perplexing to many and patients don't know a lot about and is confusing, and that is how to perform lower lid blepharoplasty. And when I say how to perform it, I mean, do you perform it from inside the lid, which is called transconjunctival surgery, or do you perform it from outside the lid, which is called transcutaneous surgery? Sorry if the video is moving around. I have my phone in my hand. The reason this is such an important subject is because those are the two means by which this surgery is performed, and I have a very strong feeling and a very strong preference about how it should be done. I personally am not a big believer on performing it through the skin underneath the lashes, which is called a transcutaneous surgery. And the reason I'm not is because there's an incidence of change in eyelid shape or pulling down of the lower lid called lower eyelid retraction that occurs from this surgery. In the literature, it's been described as high as 6 to 20%, but I do believe that percentage is way lower in the hands of an experienced surgeon who knows who not to perform this surgery on. So I'm not saying this is a bad surgery. The surgeons that do it are superb surgeons. It's not my preference, and I'll try to explain to you why. I can't afford eyelid shape changes or pull down lower lids because this is my specialty, and I get these patients referred to me to fix all the time, and I can tell you right now that is the hardest thing to fix and the most distressing things to patients. So if it's distressing to patients and hard to fix, I don't want to be in that situation. So I perform my surgeries from inside the lid, what is called transconjunctival surgery. Now that's harder. You have to know anatomy more, and it requires more experience. But everything that can be accomplished when surgery is performed underneath the lashes with an incision from outside the lid can be accomplished from inside the lid too. The fat can be accessed, it can be removed or moved around or repositioned. If there's extra skin too, you can make a small incision under the lashes and remove just a little bit of skin, but you don't have to dissect through the muscle to get to the fat as you do from the outside. And if for some reason the lid needs tightening, the outer corner can be pulled up or tightened, what's called the canthal suspension, if needed also. In addition, if more fat is needed, fat can be harvested from the belly, the inner thigh, or elsewhere in the body and injected to fill in the hollow. And if there's wrinkles, a laser can be performed too. Everything you can do with surgery from outside the lid, the transcutaneous procedure, can be done from inside the lid, the transconjunctival procedure. However, the incidence of complications is vastly different between the two. When you do it from inside the lid, there are much less complications. Now, those that are naysayers against surgery from inside the lid say it's not as powerful, you don't get as much skin, you don't tighten the skin as much. That may be true. However, if you get a complication, such as lower eyelid retraction, it is so hard to fix. And even more importantly, I've studied this, so hard to make someone happy when fixing it, that it, in my opinion, is not worth doing. And if you have an option that's safer, more reliable, and more predictable, and leads to less complications, why not do it? That's my basic feeling. The problem with lower lids is this. You can't have a cookie cutter procedure. Everyone is different. The examination is critical. Is there excess skin? Is the muscle lax? Is there excess fat? Is there a deficiency in fat? Is the lid loose? Is the skin wrinkled? All these things need to be answered, and a plan needs to be identified that leads to a safe, predictable, and reliable outcome. And what I can tell you in doing revisions for lower lid surgery is that revisions are very, very hard to get right. And more importantly, even if you get them right, it's very hard to make a patient happy. Why is that? Because the damage that was done from the initial surgery causes changes that don't have simple fixes to. The eyes and the eyelids are very, very delicate structures. You can't alter them too much and expect to have a predictable, simple fix for them. So the best way to avoid complications is to perform the first initial surgery the correct way, or the safest way. And if that's done, I think the incidence of these problems will be much lower. So again, I want to emphasize, doing surgery transcutaneously from under the lashes to access the skin, the muscle, and the fat and manipulate them is perfectly appropriate and follows the standard of care, and there's some incredible surgeons in the country and the world that do this and do it well. However, Overall, the incidence of complications from that surgery, dreaded complications, complications hard to fix, and complications that are just devastating to patients, is significantly higher than when you do surgery from inside the lid. Number two, everything you accomplish from the outside can be accomplished from the inside. What's really necessary is an evidence-based study that compares doing surgery from the inside and from the outside, addressing skin, fat, skin wrinkles, fat grafting, etc., and finding out what the overall results are and what the differences are. When that's done, we'll have more answers to this question. But I hope that provides some clarity to this, because I'm asked this question all the time. Have a wonderful day.